Thank you so much, dear colleague. Thank you for inviting me, for giving me the opportunity to be here with you to discuss about the result of the FIGHT trial. And in particular, thanks to SMT for the organization of this meeting. Regarding the FIGHT trial, the first objective of the FIGHT trial was to investigate in older patients with MI, a multivessel disease, if complete revasc based on coronary physiology and the implantation of Supraflex Cruz was superior to a culprit-only strategy. But before to show and to discuss all together the result of the FIGHT trial, it's really important to understand some important things. The first is why the FIGHT trial is unique. Because in the FIGHT trial, we enrolled patients that you see in your daily practice. Normally, if you read a paper from a randomized clinical trial, the first impression that you have, this patient is very rare. On the contrary, if you read the FIGHT trial, you will see in the population of the FIGHT trial the patient that you treat every day are patients at very high risk of periprocedural MI, have a very high risk of acute kidney injury, high ischemic risk because we are enrolled patients with MI, multivessel disease, severe calcification, high risk of stent thrombosis. And in particular, we mixed both high ischemic and high bleeding risk patients. So patients showing both characteristics. If you observe, if you compare the main data from the FIGHT trial, the baseline characteristic of the population with the other trial on the same topic, so for example, the complete trial, so comparing culprit only versus complete revasc, you immediately observe the difference. Our population was 20 years older, more diabetes, more female patient, more heart failure at clinical presentation. So in the FIGHT trial, you can read the paper that the patient that you see every day. And normally, the coronary anatomy of a patient from the FIGHT trial is like this. So chronic total occlusion, long lesion, bifurcation, severe calcification. The second question, really important, is why we selected Supraflex Cruz for the FIGHT trial. This is a very important point because 7 years ago, when we wrote the protocol of the FIGHT trial, we decided to use Supraflex Cruz for some important reasons. First, the technical characteristics. Ultra-thin platform. The presence of the LDZ link, that is a very important link in the stent between the crow to guarantee flexibility, pushability, and trackability. Second point, the biodegradable polymer eluting sirolimus in 4 weeks. This is very important to minimize the risk of stent thrombosis and to have great performance in terms of reduction of the ischemic events. At the same time, we had some important data from previous study, in particular from the TALENT trial. At 3 years, no difference with science. And all the meta-analysis suggested the superiority of ultra-thin platform in reducing the risk of target vessel failure. And obviously, on top of technical characteristic, clinical data, there was our experience. We started to work with Supraflex Cruz and immediately we appreciated the pushability, the trackability, as you can see in this case, the ability to achieve the target in a LAD with a lot of tortuosity. So based on available data, on our experience, Supraflex Cruz was the best stent for the challenge of the FIGHT trial and of the FIGHT patient. The design of the trial was quite easy. So, patient aged 75 years old or older, admitted to hospital for MI, ST segment elevation MI or no ST segment elevation MI, multivessel disease at coronary artery angiography, and the patient randomized to complete revasc guided by physiology or culprit-only revasc. The result was very, very clear and important. A significant reduction of death, stroke, MI, and ischemia-driven revasc in patients receiving complete revasc. So, the treatment of all the lesions, culprit and non-culprit, guided by physiology, allow a significant reduction of ischemic events at 1 year. The reduction of the adverse events was constant across all the secondary endpoints. You may observe a reduction in terms of death, cardiac death, MI, ischemia-driven revasc. No concern regarding safety, so no increase in stroke, no increase in contrast-associated acute injury, kidney injury, or bleeding. We published the FIGHT trial on the New England Journal of Medicine. We are very proud about this achievement, but we are here not to talk about only the FIGHT trial, but in particular to talk about some important subgroup and new analysis that we have from this trial. Regarding HBR patient, just a brief update. You saw the data from the FIRE HBR, from the Cruz HBR, from the COMPARE 60-80 trial. What we did in addition of this, we did an individual patient data meta-analysis, putting all together the data from the 3 trials. In particular, we selected from the 3 trials all the patients with HBR characteristics and with only Supraflex Cruz implantation. As you can see, a huge number of patients, and we divided the patient in 2 different populations. Patients receiving only 30 days or less of DAPT, a patient with a longer DAPT regimen. As you can see in the result, DAPT regimen was very, very, very aggressive. So no patient in the blue line receive DAPT after the first month. And the result in terms of ischemic events, equal, no difference. So if you implant Supraflex Cruz, and if you use a good PCI technique, DAPT does not matter. This is very important. In HBR patient, you may achieve the same result in terms of death, MI, and ischemia-driven revasc without DAPT. This is very important. So it's for your question. When you have a patient at HBR, HBR win, so you don't have to use DAPT. Regarding bleeding, if we don't use DAPT, we may significantly reduce the risk of bleeding complication. So this is very important because this data come from more than 1,500 patients, and data is very solid, is constant across 3 different studies, and show the safety of Supraflex Cruz. Why this safety? How is it possible? Because Supraflex Cruz, and you can read this in all the paper that we published with this stent, is the stent with the lowest occurrence of stent thrombosis. If you see the FIGHT trial, all the characteristics from the FIGHT trial suggest the risk of stent thrombosis. Older patient, MI, multivessel disease, severe calcification, bifurcation. Despite this, the rate of stent thrombosis was lower 1%. And the same thing in the EARTH HBR meta-analysis. As you can see, stent thrombosis was very low, and again, DAPT does not matter because the rate of stent thrombosis was similar in patients receiving short or long DAPT regimen. And this is true only for Supraflex Cruz. Regarding another important subgroup, really frequent in our daily practice, so patients with diabetes. Diabetes is a nightmare for interventional cardiologists because we have accelerated atherosclerosis, diffuse disease, long lesion, And I want to show you a case of a male patient, 76 years old, hypertension, prior smoker, dyslipidemia, and diabetes. The patient is admitted to our hospital for inferior ST segment elevation MI. As you can see in the angio, we have an occlusion in the posterolateral branch from the RCA, an intermediate lesion in the circ, and a long, complex lesion on the LAD. We can discuss a lot to treat only the culprit lesion, to treat all the lesion, angio-guided, physio-guided, guided by imaging. What we did? We started with the treatment of the culprit lesion. So we fixed the posterolateral branch with Supraflex Cruz 2.5, post-dilatation, and after, again, we use in the small vessel, so in the small descending posterior branch with the distal diffuse disease, a drug-coated balloon. We perform functional assessment of the non-culprit lesion, so the circ was negative, so no PCI, only medical therapy. The LAD was positive, and as you can see in the pullback is done during hyperemia, pulling back the wire. You can observe two focal drops, indicating the need of a long treatment of the LAD. We perform OCT to assess the length of the disease, the diameter of the vessel, and we proceed with the implantation of 3 stents in overlap with post-dilatation. As you can see, the final result was very good, with a good result in terms of apposition and expansion of the stent as assessed by OCT. Regarding the data of the 5 trials in diabetic patients are consistent. We observe a strong benefit in diabetic patients from complete revasc. And in particular, if you observe the figure, you observe that diabetic patients show higher risk of events, but the benefit that we may achieve with complete revascularization is stronger. So again, it's really important to complete revasc, to implant Supraflex Cruz, and to perform a good PCI technique to minimize ischemic risk, also in diabetic patients. Other important information will come from the Tuxedo 2 trial. Tuxedo 2 trial is a great trial. It's a great trial because it's not only comparing Cruz against science, prasugrel against ticagrelor. It's really important because the PCI cohort from the Tuxedo 2 trial will be matched and compared with the cabbage arm from the Freedom trial. The Freedom trial was the major trial supporting the superiority of surgery against PCI in diabetic patients. But the PCI arm was old, no new generation stent, no imaging, no physiology. So the goal of the Tuxedo 2 trial is to demonstrate that we, with new stent and with new technique, we may be better as compared to cardiac surgery. Last example, left main disease. Again, a case with effort angina, so a patient 57 years old, admitted to our hospital after coronary CT, showing a disease, a significant disease in the left main in the proximal LAD. And as you can see at the angio, we confirmed the presence of disease in the predivisional left main, and in particular, you will see in the next slide, in the proximal LAD. So we have a complex lesion in 2 different points. What we did? We proceed with functional assessment, and as you can see, you have in the distality of the vessel diffuse disease, and after you have 2 focal drop, and this focal drop needed PCI, needed stent implantation to achieve a great final result. So we proceeded with predilatation, implantation of 2 Supraflex Cruz in overlap, post-dilatation, and this is very important. Remember, in all cases when you treat left main disease to perform final POT, because with all the stent, there is the risk that the first strut remain untreated and deformed. This is very important. This is a sub-analysis from the October trial. In the October trial was implanted science, and a lot of cases show strut deformation in the first strut on the left main. So the reason may be abdominal rewiring, guiding catheter collision, but if you perform final POT, you avoid strut deformation. Strut deformation is a killer, is associated with a significant increase of adverse event and death in patients where we perform PCI on the left main. So please remember, you perform your procedure. It's not important if you use IVUS or OCT or angio. The final step is final proximal optimization technique in the left main to optimize the outcome. And in this case, as you can see in the slide, the final result was very brilliant and a very good result from PCI. Why Supraflex Cruz is perfect for left main disease? Because we have a large cell area, we have a great overexpansion capacity, we have the diameter 4.5 is able to achieve 5.5, but the main reason is this, because the design of the stent is generated to optimize the advantage of the POT technique. We see in the first slide, in the previous slide, how important is this technique to optimize the outcome. So we combine all the elements. We have a great stent technology generated to optimize POT technique. POT technique is the key point to optimize outcome when you perform PCI in the left main. So obviously, if you combine all the elements, you will achieve a great result. We have some data regarding the performance of Supraflex Cruz in the left main. Again, we put all together the trial. We extracted the patient receiving Supraflex Cruz in the left main, and as you can see, you did not observe any difference in patient treated in the left main or not. And this is incredible, because left main normally is associated with a higher rate of adverse events. But if you perform a good PCI with a good stent, you did not observe any difference. So in conclusion, many studies, because we have a lot of studies supporting Supraflex Cruz, show the remarkable safety and efficacy of this platform, also in the worst patient coronary anatomy. So the result will be great, both in worst and good condition. Thank you so much.